You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
When every decision matters, you need trusted medical intelligence. Medscape AI synthesizes peer-reviewed evidence and Medscape's expert-validated content in seconds, delivering clinically verified answers you can trust. Join over 13 million Medscape members on the world's leading platform for clinicians. Start using Medscape AI on the web or in the Medscape app. Medscape AI, trusted medical intelligence.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for August 21st, 2026, 1 week before the ESC meeting. This week, mechanical CPR devices, the dangers of AFib performance measures, 2 scholarly articles on closure and champion trials, and just a little ESC preview. I'll have more ESC preview next week. First, a quick listener feedback on the ZEUS negative trial of the IL-6 blocking drug ziltivekimab, which I covered last week. Dr. Wayne Kassemeyer, North Carolina, writes to opine that IL-6 blockade is likely too distal in the inflammatory cascade to have a positive effect. He mentioned in his email a more proximal blocker called anakinra, which I have never heard of, which works farther north, and argues that we need more trials of these different agents before throwing the baby out with the bathwater. Targeting IL-6 may be too downstream in the NLRP3 inflammasome, like trying to kill a tree by cutting off its branches instead of its roots. So we shall see, and I appreciate that comment because certainly inflammation is not one of my areas of expertise. The first topic I wanted to address today is the business of mechanical compression devices for out-of-hospital cardiac arrest. In my age, I have come to appreciate elegance in medical practice. And of course, elegance, the word, is defined as the quality of being graceful, stylish, and refined in appearance, manner, or behavior. Also, elegance, in a broader sense, the quality of being pleasingly ingenious, simple, and effective. In medical terms, elegance means things like a smaller incision, a simpler procedure, an inexpensive medication, a unifying diagnosis, perhaps with a history exam and ECG, instead of a double-secret imaging test. Or elegance can be a calm, reasonable voice at the bedside. Perhaps the most elegant of all things in cardiology is the paced QRS from a perfectly placed His bundle pacing lead. Mechanical CPR devices are the antonym, the opposite of elegance. The first time I saw one of these devices, I was aghast. What is that monstrosity torturing the patient, I asked. Well, there are now numerous variations, and one of them goes by the name Thumper. I'm not kidding. As if the thing needed any greater appeal to the hypermasculine firefighter types and ER doctors who use these things. And of course, I get the idea of mechanical CPR compression. The idea is that good quality CPR is important in the setting of cardiac arrest. Delivering good quality CPR requires training and focus and intention, all things that can vary a lot among human operators. A thumper-like device can minimize variation, and to the extent that CPR modifies survival in patients with cardiac arrest, it could improve outcomes. The journal Circulation has published an observational study, an interesting observational study, looking at outcomes before and after using a mechanical CPR device. I'm going to tell you about the paper, and then we'll review the evidence for these devices. So a group from the Mid-America Heart Institute and Emory used the CARES registry from 2013 to 2019 to take an EMS agency-level approach to survival from out-of-hospital cardiac arrest. And they did 2 main analyses. First, they did a temporal look at agencies that did not adopt a mechanical CPR device, and this was a large group of 73 sites encompassing about 52,000 out-of-hospital cardiac arrest. The second analysis looked at 49 agencies that introduced a mechanical CPR device for a before and after tally, about 14,000 arrests before and 18,000 arrests after. And the main question is, did use of the device associate with an improvement of outcomes? So it's like It's almost like an ecological study, before and after. They also ran some secondary or sensitivity analysis, such as looking at the intensity of device use, say 20% versus greater than 20%, or less than 45%, or greater than 45%. The findings. In the control agencies, they saw no significant trend in survival over the 2013-2019 period, and it was stuck around 9 to 10% survival. In the device adopting agencies, there was no significant change in the intercept or slope after introduction for either outcome. Favorable neurologic survival went from 8.9 to 8.3, and so basically no difference. Survival to discharge went from 11% to 10%, similarly non-significant. The intercept measures the moment of introduction, and the slope is obviously any trend over time. Both were negative. In the stratified analysis based on frequency of use, the post-device use trends were flat. Essentially, there was no obvious signal of benefit based on more or less usage, and the results were unchanged when 911 witnessed arrests were included. Now, my comments. I like this observational data, right? They document temporal changes in device use and then look at survival as an outcome. And they found no difference, no signal at all. Now, there are limitations of the data, including, of course, there's a lack of granular data on both the patients and the agencies. There still was not any signal of benefit. And note here that the outcome of interest was not the quality of the CPR. The quality of the CPR with these devices could have been better, but survival and survival with neurologic recovery, again, those are the important outcomes, and there was no difference. And just from a Bayesian neutral Martian perspective, looking at this from the outside, you would think that if these things were so great and adoption of these things was so prominent, there would be an uptick in important outcomes because of these devices. And then you say, okay, Mandrola, these are just observational data. There must be trials. It turns out there are trials, and they're all negative. There was a paramedic trial published in Lancet, randomized 6,000 patients to the device versus standard CPR. Survival at 30 days was similar. Odds ratio 0.86, confidence interval 0.64 to 1.15. There was a trial called the CIRC trial, published in Resuscitation, randomized 4,700 patients to mechanical CPR versus standard CPR, and again here, there was no difference. Now, this trial was declared positive because they used a non-inferiority design, but again, the outcomes were similar. JAMA published a trial called the LINC trial, LINC, randomized 2,600 patients to mechanical CPR to manual CPR, and no significant differences in 4-hour survival, survival to discharge, or survival with good neurologic outcome. And for the win, there was a Cochrane systematic review of 11 trials, which also found no evidence of benefit and a small signal of harm, actually. So I've looked at this data before, and maybe I've mentioned it over the last 10 years 1 or 2 times, and I've asked an emergency medicine specialist, why are these devices so popular? And that person couldn't give me an obvious answer. I mean, they certainly market these devices, and you can find lots of short videos with fancy music and all kinds of stuff with these devices. But again, there's just no empirical evidence. Now, maybe buried in this negative data are there patients who could benefit, but I doubt it. I think there's also a good lesson in causal inference in this case. Causal inference and surrogate markers, I should say. Why is there no benefit empirically? Why are the trials negative and the observational studies negative? Well, let's just set out that the device is somewhat marginally better at CPR than humans. But good CPR is only one thing on the causal chain to survival in out-of-hospital cardiac arrest, right? There are many other factors. The underlying disease is a factor. The time to starting CPR, the time to defibrillation, and the quality of the care in the hospital afterward. In other words, there's just a lot of things besides good quality CPR that goes into a good outcome. And I would say, given the aggressiveness of these devices and their cost, approximately $20,000 plus the disposables on many ambulances, I would think we would abandon them. That is, if the treatment of patients with out-of-hospital cardiac arrest is to remain an evidence-based intervention. Of course, I'm interested in any experts who can counter this slew of negative data and convince me that these very aggressive jackhammer-like devices are worth using. I certainly can't find empirical evidence for that. Okay, let's move on. Next topic are ACC AFib performance measures. In JAC, a group of experts have published a document called the 2026 Clinical Performance and Quality Measures for Patients with AFib. Why would they publish such a thing? Well, they write, quote, improving adherence to evidence-based recommendations equitably in AFib is critical to advancing clinical care, patient outcomes, and public health. I and you should worry about this next quote that I'm going to read you. Quote, the writing committee developed a comprehensive set of 5 performance measures which are appropriate for public reporting or pay-for-performance programs, and 16 quality measures which are useful to clinicians and healthcare organizations for quality improvement. Now, I will tell you what some of these measures are, but I want to say how worried I am about performance and quality measures in many conditions, especially atrial fibrillation. And the problem with codifying AF care is that the condition is so variable that it defies algorithms. Even worse, trying to fit patients into performance or quality algorithms can cause harm. I'm sure of it. We've seen this in heart failure care. I see it almost every day in the hospital. Now, will we all agree that in youngish, ambulatory patients who have good blood pressure, the rapid initiation and titration of 4-drug therapy is reasonable and transformative? Making GDMT a performance measure, though, has led to the wildly inappropriate use of these drugs in older, frail patients with comorbid conditions. I bet I see at least one elderly patient a week who had a complication of overzealous use of GDMT. Mostly falls from low blood pressure, but also hyperkalemia and acute kidney injury as well. This happens in heart failure because the condition clusters in the elderly, but the trials were done in younger, robust, ambulatory patients. The variability of AFib, though, is even greater than I think in heart failure. For instance, you can have a patient who has ischemic cardiomyopathy, low ejection fraction, left bundle branch block, who develops AFib, and this is a life-threatening condition, and it needs prompt action. These are the sickest of patients with AFib. But the very next AFib patient could be a 64-year-old who has no medical problems, who is found to be in totally asymptomatic AFib at a visit for general follow-up. And then the next patient you see could be a 40-year-old runner who has 10 to 30 minutes of AFib on his watch once a month. And these are all patients who have electrical AFib on their monitor, but they're completely different. It's a simple, irregular, rapid rhythm on an ECG, but the way it affects humans is off-the-chart complex, and trying to fit these patients into an algorithm, I think, is simply wrong-headed, wrong thinking. All right, let's just talk about the performance measures. Performance measure number 1. Do a basic evaluation and make a proper diagnosis. Why do we need a performance measure for that? That's basic doctoring 101. Of course, we want to document that it's AFib and not SVT or not atrial tachycardia or not PACs. And of course, we want to evaluate the patient to see if they have hyperthyroidism or something like that. Performance measure number 2 is to do comprehensive care and secondary prevention AFib, such as patient education on weight loss, reduction of alcohol, assessment of sleep apnea, etc. And I think this is a great idea. But again, the first patient I mentioned just above, who has ischemic cardiomyopathy, low AF, left bundle, and heart failure, they need all effort on early and immediate treatment. It's not time to worry about documenting a discussion on alcohol and sleep apnea. These are just distractions of taking care of a very sick patient. By the way, I worry that the push to diagnose and treat every human with sleep-disordered breathing has run amok. This is a sidebar, but I'm seeing underweight 85 and 90-year-olds who complain about having to wear a CPAP because their doctor wants them to wear a CPAP. And I would say to all of my friends, if your patient is 90 years old, they have graduated from wearing devices at night. Okay, performance measures 3 and 4, documentation of stroke risk and use of anticoagulation when indicated, and that seems fine on the surface, right? But I'm getting a lot of CHADS VASC alerts in my electronic health record because my patient with a score of 2 who has had no AFib a year out from ablation is no longer taking oral anticoagulation. They still have a diagnosis of AFib in the chart, but they're not on anticoagulation because we have 2 trials. This falls out of the performance measure. But again, we have 2 trials showing that it's reasonable to stop anticoagulation if it aligns with the patient's goals. Or another example, what about the person with a pacemaker who has subclinical atrial fibrillation of short duration? That patient has a diagnosis of electrical atrial fibrillation, and we've already discussed the wash between stroke reduction and bleeding increase seen in the subclinical AF anticoagulation trials, NOAA and Artesia. And the patient does not want to use anticoagulation, which is totally reasonable. Subclinical atrial fibrillation is a different entity than old-fashioned clinical AFib. So these performance measures are clearly not ready for public reporting or pay for performance. It would be a huge mistake. All right, now let's just look at some of the quality measures that they listed. I think these quality measures they listed would be an even worse idea if we started using these for public reporting or for modification of behavior. All right, quality measure number 1 is equitable AFib management. I have no idea what that means on a physician level. The irony here is that I have read papers that say some underrepresented groups of people have a lower rate of getting left atrial appendage closure. Well, that is an inequity we can be glad about. Here is another example. This is when experts think it is a good idea to improve access to complicated procedures like AF ablation or TAVI by opening low-volume centers in rural areas. Yes, this increases access to the procedure, but it also exposes these patients to a higher risk of complications because of low-volume centers. The fact remains that I think the Canadian model, where complicated procedures are concentrated in high-volume academic medical centers, is likely the best way to reduce complications. The trade-off, of course, if you concentrate procedures in expert high-volume centers, is there's going to be longer wait times. Of course, there's always trade-offs to these things. All right, let's talk about quality measure number 8, inappropriate prescription of flecainide or propafenone to patients with AFib. Now, I wonder what this means exactly. Yes, these are not great drugs for patients like CAS-like patients who have post-MI LV dysfunction, but it's now common to read editorials describing, correctly in my opinion, the overgeneralization of the CAS trial. And CAS has been overgeneralized to prohibit use of 1C drugs in any patient with a sliver of heart disease, which is not what CAS was about. These drugs, the 1C drugs, can have a role in patients with symptomatic ectopy or paroxysmal atrial fibrillation, in patients who have coronary disease that doesn't have ischemia, yet that would risk getting you dinged on this quality measure. So I don't think we've sorted out the appropriate use of 1C drugs exactly. Certainly the black box warning from CAST is too much. All right, quality measure number 11. Catheter ablation of AFib for patients with symptomatic AFib. Now, I spend a lot of my time doing AFib ablation, and PFA has made it much better. But this, of course, is a preference-sensitive procedure. I have many patients who say, thanks, but no thanks. I'll keep taking my antiarrhythmic drugs, and the episodes that I have are not bothering me that much, and we don't need a quality measure to encourage more AF ablation in the U.S. If anything, we should encourage a slower AFib ablation after a period of risk factor management, after a period of time to see if atrial fibrillation will go away or become manageable by the patient. Quality measure number 14, AF rhythm control in patients with HFrEF. Again, this seems good on the surface. I think EP and heart failure community should talk more to each other in the hospitals. And to my heart failure colleagues who might be listening to this, I would encourage you and your colleagues to call EP, that we can help when a patient has heart failure and atrial fibrillation. But I would never want to see a quality measure that encourages rhythm control algorithmically for all HFrEF patients. Sometimes, yes, amiodarone, cardioversion, then ablation is the correct answer. But sometimes the digoxin is the correct answer. Other times it's AV node ablation and conduction system pacing. And so again, it does not fit this algorithm. So my final comments on this is, when it comes to policies and algorithms, I would ask key opinion leaders to resist the urge to help us. If I was a czar for performance, I would implement some much simpler measures and a lot fewer of them. Okay, one would be any center that does ablation should have to report basic results. Serious complications should be public knowledge. Vascular access issues and pericardial tamponade rates should be publishable. It should be knowable. Everybody should know it. And we don't have that data. If you're signing up for an AFib ablation at center A, you might not know what their vascular complication rate is, and you should know that. Second, AF ablation success rates are more problematic, right? Because success of AF ablation is hard to measure. It varies on how much monitoring you do. It varies on the complexity of patients that you decide to do. So I don't think we're ever going to have successful AFib ablation success performance measures. I would favor a performance measure on cardioversion of AFib. Here, there is a right and wrong way to do it. The right way is to cardiovert the patient with AFib with maximal energy. If you cardiovert the patient with AFib with less than maximal energy, you should get dinged on the performance measure. It's a dumb thing. I think it's one of the best ways to find an uninformed doctor is to find one that tries to cardiovert AFib with less than the maximum energy. And finally, this idea isn't ready for implementation yet, but I have long felt that a very good measure of quality of care would be to quiz the patient about what they know about their plan. Now, I recall the irrational exuberance days of the ICD, and it was terrible how few patients understood the purpose of the device. And we had many papers looking at what patients understood about ICDs, and it was universally terrible. I would like to see more of these studies on assessing patient knowledge of AFib. A well-informed patient is one of the best signs of a good AFib program, in my mind. Okay, next topic is two critical appraisals of the recent left atrial appendage closure trials. The first, Dr. Jared Bunch and co-authors writing in Heart Rhythm Journal have an open access piece worth reading on the guts of the non-inferiority analysis of Champion AF. People often ask me, John, how did you learn to do critical appraisal? And my answer is that there's not one way to learn critical appraisal, but there's many ways. But one sure way to get better at appraisal is to read excellent works like this one. The first author, by the way, is Dr. Anish Shah, and I would read this paper. They explain in great detail the problems with the Champion endpoints and non-inferiority analysis. I reviewed them previously. Okay, briefly, they point out that adding cardiovascular mortality, which is an endpoint not affected by anticoagulation or appendage closure, is a problem, because when you do that, you get more CV-DAST, you get more endpoints, which is pragmatically useful for limiting trial costs, but problematic because it biases toward non-inferiority, right? Adding an endpoint not affected by the treatment adds equal numbers of events in both groups, and it makes non-inferiority to reach, because in non-inferiority, no difference is a positive result. The authors also speak about the problem of the non-inferiority margin being set only on an absolute scale based on expected rates of 12%. So they pick a margin of 4.8%, meaning that the worst case scenario, if it's less than 4.8% in the confidence intervals, then it's declared non-inferiority. But that's based on a observed control rate of 12%. So if you do basic algebra, you'll find that 4.8% of a margin of 12% is a 1.4 relative risk margin. But when the observed events come in not at 12%, but 4.8%, now a 4.8% margin allows a non-inferiority margin of 2. No one wants to accept a therapy that's 2 times or doubly worse. They explain the proper way to assess non-inferiority margin is to use both absolute and relative margins, and I've talked about this before. And in Champion, the upper bound of the hazard ratio of the primary endpoint reached 1.6, which is greater than 1.4, so the trial should have been declared not non-inferior if they had done it the proper way and the editors had held them to that. Now, the authors also explain a more subtle concern in how the margin was generated in the first place, and do read their explanation, but in sum, the non-inferiority margin is derived from the VKA versus placebo trials, right? You want the new treatment to be better than placebo. The issue with Champion was it enrolled a different population that was more consistent with a primary prevention cohort. And they write that by including the secondary prevention trials in the historical sample, the Champion authors create too lenient of a non-inferiority margin. They go on to explain that falling stroke risks over time, which we've seen temporally, it would compel the authors to use a much tighter non-inferiority margin. They even add a Bayesian analysis as well, and the Bayesian analysis is sobering because the probabilities are far less than what we would want with an invasive stroke prevention procedure if we were doing it instead of anticoagulation. The second paper that I'd point you to is by Dr. Omerovic and Redfers, and they have a similarly well-argued piece, and it's in European Heart Journal. Their focus is also rightly is on the uncertainty in the both trials' effect size. They start with Champion and they re-summarize the problems with the non-inferiority margin, the higher rates of ischemic stroke in the appendage closure arm, and of course the decision to exclude non-procedural bleeding in the safety endpoint. They add to the worry about the higher ischemic stroke rates in the appendage arm the device-related thrombus rates of nearly 5%. They then address closure, the German trial, and that stroke rates were similar between arms. The primary endpoint in closure was driven substantially by both bleeding and mortality emerging beyond 1 year. But of course, mortality is not going to be affected by either arm. Next, they discuss the differing causal environments of the two trials. Champion primarily was conducted in high-volume, largely U.S. centers with a single device platform, and these were fairly low-risk patients, while Closure enrolled an older European cohort and they used multiple devices. And the authors ask, do the results transfer to all settings? And it's a good question, right? It's the question. And they argue that this leads to residual, they call it epistemic uncertainty. I would just call it uncertainty. Their next heading is super interesting, and they call it the social life of trial labels. Quote, trial outcomes function as social facts. Once collectively designated positive or negative, a label acquires institutional reality that resists later statistical qualification, and can they be more right about something? Then they add this, and I'm directly quoting here, quote, the structural conditions for this dynamic were established before Champion AF's results were known. The trial sponsor manufactured the device, collected the data, and conducted the analyses. This describes a configuration in which the party producing the data had a direct stake in a specific outcome. Investigator-initiated trials, they go on, have their own vulnerabilities. They have insular peer review, narrower regulatory engagement, and underpowered designs, as raised in the Prague 17 investigator-initiated trial. The argument, therefore, that they make is not that one funding model is purer, but that the post-approval architecture should not depend on either alone. Negative labels rarely operate as a symmetric counterweight. In device trials, they're commonly attributed to the trial population rather than to the device. The uncertainty of how to translate trials in separate environments caused the two Swedish authors to argue for something I totally agree with, and that is that new therapies should be introduced through coordinated prospective post-approval implementation trials that can be embedded in routine care, and I could not agree more with that. Now, they point to the Sweetheart program there as a potential example of being able to do this. And I strongly believe that this should be where the next chapter in cardiology evidence generation should come from. Yes, of course, we need to keep iterating. Please make better TAVI valves, make better devices. That's all great. But what we really need to know is how these new therapies are going to behave outside the confines of very special trial environments. How do they do in Louisville, Kentucky, or Rzeszów, Poland, or Sydney, Australia? In left atrial appendage closure, my take is by no means should Champion in closure argue for replacing DOACs with left atrial appendage closure. But we still don't know how left atrial appendage closure would perform in patients who struggle taking anticoagulation. For this, more trials are needed, and I think every patient who cannot take anticoagulation who's referred for appendage closure should be in a trial. And if we had such a trial, we would know. Of course, now is not the time to be doing this. Time to do it was before 600,000 of these devices have been implanted. Finally, here on This Week in Cardiology, I am often critical of journal editors, but I need to commend the teams at Heart Rhythm Journal and European Heart Journal for publishing such fine examples of scholarship. These are serious papers with serious arguments. You have to read them slowly, and you have to think about the statistics and the models and the choices. And that's how cardiology used to be. We were leaders in thinking, and I hope that thinking makes a comeback in cardiology. All right, finally today, a little bit about ESC. The big ESC meeting starts next Friday, literally next Friday. I will have a written preview out next week on the heart.org Medscape, and nearly all the hotlines are going to come after next Friday's podcast. But there's going to be a couple on Friday that are worth talking about today. I looked at two that caught my mind that are going to come out Friday, and that will be available before the embargo when this podcast posts. The CMR guide trial is a primary prevention ICD versus a loop recorder in patients who have an EF of 36 to 50% and documented SCAR on CMR. So SCAR is a high-risk factor for sudden cardiac death, and the idea is, can SCAR be a risk stratifier? The primary endpoint is time to sudden cardiac death or significant VT. Now remember, most ICD trials have been just alive or dead mortality. Here, there are only a few hundred patients enrolled, and they've powered the trial to reduce the primary endpoint by 55%. So, although it's a great question and it's an interesting trial, I worry about power, and we shall see the results. Then there's another one. This is interesting. The single AFib trial is a provocative South Korean trial of anticoagulation versus no anticoagulation in patients with AFib and a single risk factor. That's CHA2DS2-VASc1 in males, CHA2DS2-VASc2 in females. The primary endpoint is stroke, systemic embolism, major bleeding, or CV death at 2 years. 900 patients in each arm. And I think this too is going to be a wonderful trial, as we will learn the base rates of strokes in intermediate risk people. I predict that what we call intermediate risk patients now will actually look a lot more like low risk people. And the same problem applies, right? When these results are null or not superior for anticoagulation, we may have wide confidence intervals, and instead of calling no difference, we may have to say that the trial was uninformative, and yet we don't know. Yet at least we will get a picture of what contemporary stroke and bleeding rates look like in these very, very common patients. So next Friday, I'll have a preview on the podcast of the upcoming trials. I'll have some of the news on these early trials, and do look for the written column coming up next week. I arrive in Munich on Friday morning. I'll be there through the weekend, and do say hello. I really appreciate when you come up and talk to me. Until next week, from Munich, Germany at ESC, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.